and welcome. After a long gap, we again started our regular program under the ECG study group, ECG Basic and Beyond. Today is our 103 lecture session, and our presenter is none other than Professor Abdul Chowdhury sir. Part of the session, as the norm, I'd like to request Professor Rafique Ahmed sir to say some word regarding Abdul Chowdhury sir, and then we proceed. Rafique Ahmed sir.
Assalamu alaikum. Good evening. Welcome everybody to this session. This session has been the brainchild of Atahar and Wadud, and we have been continuing it for now how many years? 4 years plus?
Great, sir.
Yeah.
It's almost 7. If we
7
start
years?
from the beginning, almost 7 years, sir.
Yeah. I hope, and I think it is making some impact throughout the country, discussion of basic ECG, and then from basic to complex, and we have covered everything. We have good speakers. We have the panelists, a good group of panelists here who are all dedicated. So today I'd like to introduce Professor Wadud Chowdhury. He doesn't need introduction. He was Professor of Cardiology at Dhaka Medical College, now Professor of Cardiology at National Institute of Cardiovascular Disease, and also the director here. Excellent speaker. I always enjoyed listening to Wadud. So without further delay, I would like Wadud to take over the microphone.
Thank you, sir, for your kind words. Let us share the screen. Today, actually, I'm going to talk about the very basic things. So our learned faculty may find it very simplistic. Let us see. Yeah. ABC of ECG series. That's what we have started now. A new cycle, starting from the very basic, we'll be going into deeper issues, and we'll be dealing with clinical issues in between. Now, when we think about the heart, we should remember that it's an electrical organ, and its activity can be measured non-invisibly. And ECG is that tool which can actually give you the impression what is going on regarding the electrical activity of the heart. And electrocardiogram is nothing but the graphical representation of the electrical activity of the heart as a whole. And now, if you consider the history, the first human ECG was recorded by Wellard in 1887. And then Einthoven, a very remarkable person, he recorded 4 deflections with a refined electrometer and initially labeled them as ABCD. Later, he chose PQRST instead of ABCD. And Einthoven started using sting galvanometer, and he also identified the E-wave. He was a Dutch doctor and physiologist, and he received the Nobel Prize in Medicine in 1924 because of his contribution in doing the first practical electrocardiogram. Now, at that time, a person who is having a leg submerged in salt water and the big machine, that's what was used for recording an ECG. And nowadays, look at this, a trolley with an ECG, with a printer and screen and everything. And we have very small ECG recordings which can be used at home. Now, what are we going to use with ECG? We can identify arrhythmias. We can identify myocardial ischemia and infarction. We can identify pericarditis or chamber enlargements and hypertrophies. We can gauge some electrolyte disturbances, and also some drug toxicities can be identified from the changes that occur in ECG. Now, an electrogram is from inside the heart. An ECG is a surface ECG. That's recording the summation of the electrical activity that's going on in the heart. An electrocardiogram actually identifies the pinpoint what is happening in the SA node or in the AV node, in the junction or his bundle, like that. But the ECG records it as a whole. And so we come to conclusion that ECG is a non-invasive technique. It's inexpensive, simple, reproducible. But we should remember, ECG diagnoses are valid only if the electrodes are placed in correct anatomical locations. Lead wires are attached to appropriate electrodes, and recording is of good technical quality. This is the basic thing. Otherwise, your reproduction of an ECG may not be that much reproducible. And whenever you are recording an ECG, we should check the cables, whether they're connected well, the surface is clean and dry, the electrode and skin, good contact is there by using a jelly or something like that. And we should enter the patient data on the printout, because otherwise there'll be some mistakes when we are actually going to use one patient ECG as another, and there may be some clinical mistakes. Now we have 12 leads from 10 electrodes. 6 leads are precordial, V1 to V6. 4 are limb electrodes, 1, 2, 3, and augmented leads, VR, VL, VF. The limb placement, look at this one. Anywhere on the limbs, you do not have to put it on the foot or on the wrist. Any stump on the shoulder or in between, you can put it there. It will be equally effective as a limb lead. What about the chest lead? The anatomical locations are there. The second intercostal space, tangular fluids, we know that. In the fourth intercostal space, just on the right of the sternum and left of the sternum, that will be the V1 and V2. And just below the nipple, there's the fourth intercostal space. Just below the nipple, where is the fifth intercostal space, we are putting the fourth one. In between will be the third one, V3. And from the fourth one, just go horizontally, laterally. On the anterior axillary line, that will be the V5, and mid-axillary line, V6. So it will be only 2 intercostal spaces, but sometimes we make mistakes. That's what, if we do a cut section, we'll find it like that. And here you look at this one. V1 is just on the right of the sternum, midline. And so it's more recording a better activity of the atrium. V2, just over the left side of the midline of the sternum. And whenever we consider posterior leads and other things, V2 is the most important thing. V3, V4 on the apex, V5, V6 on the lateral walls. What about the right-sided chest leads? The other way round, the same way, on the fourth intercostal space on the left side, V1 right, on the right side, V2 right, just below the right nipple, V4 right, and in between V3 right, V5, V6, etc. What about the posterior leads? You just take off the V1, V2, V3, or V4, V5, V6, any three. I prefer keeping the V1, V2, V3 in place and taking out the V4, V5, V6, and then put it V7, V8, V9, posterior axillary line, in the same horizontal plane as we have placed the V4 lead, V5, V6 lead, in the same horizontal line. Is posteriorly. Posterior axillary line, midscapular line, paraspinal line, V7, V8, V9. They'll be recording the posterior surface of the heart quite well. Now, all of us know what interval has started, leveling SP, QRST, and new waves, etc. And the segments, the PR segment, ST segment, PR intervals, QT intervals. And between the TP segment, there's the period of electrical, so-called electrical cycles. Now, here, there's some standardization, because if you do not have the standardization, how can you compare one ECG from another, one machine's ECG from another? So the standard calibration is that 1 millivolt of current will produce a 10 millimeter deflection. So let me see.
Sir,
Pointer.
from beginner's point of view, we use the term augment. So can you please clarify why it is augmented limb leads and how it is formed? Because the chest leads and limb leads are understandable to all, but why it is augmented limb leads?
The augmented leads are actually using the keeping the one end is the electrical neutral and keeping the another lead in a place. Let's say AVR. This you are looking at the heart from the right shoulder tip. And it's augmented because the actual electrical current that's been seen there, it would have been small. And when we put the other three limb leads together and make it a neutral, it becomes a little bit bigger. That's why it's augmented. And same way, the AVL, that's from the left shoulder you are looking at the heart. And the AVF is from the just straight line bottom, you are looking from the navel, you are looking at the heart. The augmented means you are actually enhancing the electrical signature much more by making the other leads as neutral. Now, the standardization calibration, there is one lever will produce a 10 millimeter deflection. The basic rule of ECG is that if its current is going towards a lead, what is a lead? I call it an electrical window through which I'm looking at the heart. So let's see lead one. Let's think about your pocket. Lead one is straight top of the pocket. From the left side, top of the pocket, you are looking at the heart, straight way. So any current that's going towards the left side will produce a positive deflection. If it is going right away, it will produce the highest amplitude deflection. If it is going just, let's say, from the third the button is going up towards your left shoulder, and that's going to the left side, so there'll be a positive deflection, but that the amount of current that's going there is, if you consider it's a physics as a vector, part of it, the current is going towards the left side, part of it is going up because it's an angulated. So the deflection will be smaller. So any current that's going straight to the lead will produce the highest deflection in that lead. That's going partially towards that lead, it will produce a partial amplitude deflection. And if it's going away from the lead, same way it will produce a negative deflection. If it is going away straight from that lead, from the lead's perspective, that will produce the highest negative deflection in that particular lead. And if it's going away in angle, that will produce a partial amplitude deflection. But the standardization is that any 1 millivolt current will produce a 10 millimeter deflection. So that's the thing we consider. Now, what about 5 millimeter equal to 0.5 millivolt, 10 millimeter to 1 millivolt? It's like that. The horizontal axis, what is that? It's time.
So, Wadud, so basically, there is a complex formula they use for the limb leads, and then it is augmented rather than how much they pick up. It is the machine augments this tracing, right?
And we should remember that particularly is true for lead 3. Lead 3 is actually not a recorded deflection. It's a make-up deflection made by the machine.
Exactly.
And that's why we sometimes find that something in the lead 3 T-wave inverted or something like that's not always actual situation. Now, that on the horizontal axis is actually time. And the current is going from starting from the SA node through the atria into the FE node, then the bundle of his into the right bundle, left bundle, anterior physical, Purkinje fibers, and through the ventricular muscles. And the speed is depending upon that. It will be very narrow compress or wide compress, because in the electrical tissue, the current has much higher speed. In the muscle tissue, plain cardiac muscle tissue, the current has lower speed. That means the complex will be wide because it takes time from going from point A to point B. But when it is going through the actual electrical bundles or electrical line that's originally present, is going much higher speed. So the current will be going very sharply from point A to point B, and that will produce a narrow complex. And that's why in LBBB, left bundle branch block, if the left bundle is not passing the current as quickly as it is used to, the current will be passing through the ventricles, and that will take time. That's why the left bundle in LBBB, we get a wide complex, or same thing with complete right bundle branch block. Or in case of pacing rhythm, the same thing happened. In case of right ventricular pacing, we're starting the electrical stimulation from the apex of the heart, and it's going up and away and all over the ventricle through the muscles. So it takes time to pass the current through the muscles, the complex become bigger. In case of biventricular pacemaker, we get a narrow complex because we are getting the right and left ventricle simultaneously paced, and the current going through one ventricle is merging with the other ventricle's current, so relatively narrower complex. Now, when consider the distance, the standard deviation is that the speed of the paper is 25 millimeter per second. So that's 5 big boxes equal to 1000 milliseconds. So 25 millimeter, 1000 milliseconds. Each box, a small box, is, look at that one big box is 0.2 millisecond. Small box equal to 30 millisecond, 0.04 second. And the magnitude of the current, look at this one, SA node, the current is going through the atria into every node, having a delay, they're passing through the bundle, and going into the ventricle, through the right ventricle into right, through the right bundle, and through the left anterior posterior physical into the left ventricle, and then spreading through the muscle through the Purkinje fibers. And as I have already mentioned, the magnitude of the deflection will depend upon from which lead you are seeing it. So when the current is going from, let us say, ventricle from this part to this part, if the axis is like this, current is going through this, we'll get the, in case of limb lead 2 will produce the highest deflection. But if there is chamber enlargement, for example, if this right ventricular enlargement, so the current will be going from, much of the current will be going to a much higher muscle tissue, that's the right ventricle, and some current will be going to the left ventricle, and there will be, I would say, the sharing of the common current going towards in two places. There will be deflectional change in the size of the ECG, and we can see, depending upon the in which leads we are seeing the highest deflection, we can say we are having right ventricular hypertrophy or the left ventricular hypertrophy. So whenever we are seeing at the right ventricular leads, the leads which are placed over the right ventricle, for example, V1, V2, if we get a tall R in there, then we can say there is a right ventricular hypertrophy. And if the axis is going towards the right, we can say, yes, most of the current is going towards the right side. That means there is an increased muscle mass in there. And whenever we have left ventricular hypertrophy, the axis is mostly from top to the bottom, from right to the left, from top to the apex. So if there is left ventricular hypertrophy, the current will be going more towards the left, more towards the upside, because the muscle mass in here will be much more. So instead of axis being towards the bleed 2, the axis may shift from there to towards the lift 1 and maybe towards the AVL. So left ventricular hypertrophy will produce much higher level of current in the leftward shift, leftward side. So as a whole, the whole direction of the current, summation current, will be going towards the left side. In case of right ventricular hypertrophy, when we have much higher muscle mass in here, the maximal amount of current generated here compared to the normal left ventricle, and there will be shifting of the axis. Instead of going towards like this, the shift will be gradually shifted to the right side, and there will be shifting like this. So we'll get bigger complexes in lead 3, lead 2, and also in AVR. We are seeing where the thing started. Now, look at the P wave. We do not record the electrical activity of the SA node generation, electrical activity generation in the SA node. We actually record the atrial depolarization. So when we do the intracardiac electrocardiogram, we can actually see the current generated in the SA node, pinpoint. The PR interval that records the current generated in the P wave, depolarizing the atria, reaching the at AV node, and then passing from there into his bundle, that level, the PR interval. And then the ventricle start depolarizing through the bundle branches, and they produces the QRS complexes. And then the heart starts relaxing, and there is repolarization, actually resetting of the whole thing so that the electrical activity can start again. And that's why ST segment atrial comes into play. Why this is important? We know that some physiological terms like absolute refractory period. What does that mean? During the absolute refractory period, the heart cannot be stimulated easily. During the late phase of that period, the heart can be stimulated with big enough stimulus. And depending upon that, the heart, when the time of transition, may be vulnerable to jumpstart another beat prematurely. Let's say I'm putting a stimulus in here. It will not activate the heart. I'm putting a stimulus in there, where the heart just started to relax. At that time, it's not supposed to get stimulated. The next beat is away from here. But if we put a stimulus big enough in here, there may be a jump starting of another wave, and that will disrupt the normal electrical activity, and this will create some arrhythmias, fatal arrhythmias. What about P waves? When we see atrial fibrillation, the normal sequence of starting of current from the SA node going into AV node, atrial depolarization, everything is gone haywire, because all over the atria, there are multiple sites of electrical activity that starts, and because they are starting everywhere, there is a small amount of muscle tissue that are available that they can depolarize, because the neighbors are also getting stimulated by some other point of stimulation. So in case of atrial fibrillation, we see so many focus of electrical activity, the muscle do not contract concurrently, simultaneously, in a synchronized way. So we have an atria that's just shivering, but not contracting. We lose the contribution of the atria. And we do not see any P wave in there, because the depolarization of the whole thing is not there. So all these things, the P wave, the PR interval, and why we are talking about this, these are important. Because if we have a focus, let's say, very near to the AV node, and that will go into AV node very quickly. So the PR interval will be very short. It will come like this. So we are saying it's a low atrial rhythm. Why are you saying low atrium? Because if the atrial focus is like this, the current will be going towards the ventricle through the AV node, and it will be depolarized in the atria from bottom to top, not from top to bottom. So the P wave current, if we consider lead 2, the current will be going away from the lead 2. We'll see a negative P wave in case of a very low atrial rhythm. And the PR interval will be very short. That's how we can say it's not the normal sinus P wave. Let's see. So, in short, time in seconds or milliseconds, we describe like that. Amplitude we describe in milliform. Direction we describe in axis. It's the left axis, normal axis, right axis, like that. So, as I have said, the SL node, starting of the electrical activity, atrial depolarization, we see it as the P wave. AV node passing through it and going into the ventricle, and that's the PR interval we are seeing. The ventricular depolarization is coming into play, and that's manifested electrical activity as QRS complex. And the ST segment, starting from there, the ventricular depolarization and the electrical resting period in between the two complexes. If you consider the area
So,
which
Wadud,
sir,
can I make any comment? Can you go back to the previous? So,
Yeah.
In the surface EKG, often we don't pay attention, but the P wave axis is also important to know
yes,
where is
yes,
the P wave coming.
yeah,
And then the P wave is too close, and Rafique bhai is here. It is too close to QRS or immediately after, that will determine where the P wave coming from, right? So
yes,
that is something to consider. And I'm like not an EP doctor, but I take it simply that if the QRS complex is narrow, then probably it is following the orthodox pathway of electrical circuit system. But if it is muscle to muscle, then that is QRS wide. And the QRS can be wide because, we talk about right bundle branch block, left bundle. I think it is a misnomer. We should
yes,
call it
yes,
right bundle branch delay, left bundle branch morphology delay, because there is no block, there is no transection of the right bundle. It is a misnomer. So when there is a right bundle conduction delay, we see a right bundle pattern. If there is a left bundle delay, left bundle pattern. When there is a muscle to muscle, it is very wide, and that we see, for example, in accessory pathway WPW. When it follows the orthodromic, then it is QRS narrow, orthodox. But when it is antidromic, it goes through the accessory pathway, then goes to the muscle, and then wide QRS and antidromic. I will stop there. You have any comment, or Rafique bhai, any comment? This is like the most simplest way I can think of.
But this is very important because people think when I say right bundle block or left bundle block, we are just not having any current passing through those fascicles. That's not true. The current is going through there very slowly, but it's passing through the muscle relatively at a better speed. But that speed is much slower than the normal speed that the current needs to pass through in the normal circuit. That's the point. Rafique, sir?
So I have a little different view. And I had this I had this question always in my mind, that when we call left bundle, is it really block or delay?
Really?
And because sometimes I'll see patient with left bundle few days later, another EKG right bundle, but they are not in complete heart block. But
Yes.
there is a group in Chicago, they did a fantastic study. Actually, they showed that there are two kinds of left bundle branch block. One type, there is complete left bundle branch block. They have put electrode on the left side and they have proven that there is complete block. And the way you know that complete left bundle block is there is a notch in lead 1, which is 75 milliseconds. We'll talk about this. So actually, we are all talking about the same thing. There are some cases where there is complete block, others there is delay. And the delay on the left side has been proven. Right side, we have no data.
And Rafique, I thought you will also explain why there is a rate-related bundle formation happens sometimes.
Yeah.
What is the underlying physiologic property?
Sure. I mean, I had the temptation of talking about it today, but I left it for next time when somebody will be talking about bundle branch block.
Okay.
I
Yeah.
thought keep it simple.
That's a very important thing. So when you consider which lead will see which part of the heart,
So sorry,
definitely
Wadud,
see.
I wanted to start the fireworks a little bit.
Yeah,
Sorry to interrupt.
I enjoy it. And actually, in my classroom, I used to ask the student from the very first slide, I let them ask questions or make comments. So when we see the leads, V1 to V6 is looking at the heart in the anterior surface, AVL 1, AVL 5, 6, they're looking at look at this one. Lead 1 is looking from the top of the, just have a look in there. Keep a pocket in there. So top of your pocket, and you are looking from lead 1 towards from the left side to the heart. You are looking from the left shoulder to the heart. And the precordial is, you are very closely looking at the heart. The limb is, they're looking from a distance to the heart. That's the thing. So when we have the posterior wall, we do not have any V1 to V6, we do not have any lead, which can actually have a real loop in the posterior wall. But if we consider the V2, we are supposed to have something, some changes in there, because there will be the reverse change we'll find in V2. And if you put the lead in V7, V8, V9, as we have shown in the previous slides, then we can actually see what is happening in the posterior wall. What about 4, 5, 6? V3, V4 near the apex. V1, V2, the septal wall. That's coming from here to there, oblique way, and you can see V1, V2, V3 more on the interseptal area. 3, 4 also at the apex, V5, V6 more the lateral wall. So the inferior surface are presented in lead 2, 3 AVF. Actually, this 1, 2, 3 AVF and all this, they're confusing. Because starting from 1, you look at the heart from the lateral limb. So why not put AVL after that and V5, V6 after that? But conventionally, we have started like that and that's been continued. So if you consider here, lead 1, AVL, 5, 6, lateral wall or anterolateral wall, whatever you say, 2, 3 AVF, you are looking from the bottom to the heart, the inferior leads, these 3, and they actually look at the inferior wall of the heart. V1, V2, and also V3, we call it septal or anteroseptal, whatever you say. And V3, V4 also involving actually, usually involving V2 to V4 or V5 maybe, anterior wall. So when we have the understanding that which lead being used to look at which valve, then we can start how to interpret the ECG. When we see ECG, always please remember to do something, and that will be your second nature to do so. Identification. Is this the ECG that you are supposed to see? If Mr. X is coming with a ECG, be sure that it is really Mr. X's ECG, because there has been chance of misplacement and creating misunderstanding and sometimes misdiagnosis. And also, after that, look at the standardization, the calibration, the speed. Make it a second nature. It doesn't take more than 2 or 3 or 5 seconds. Then go through a systematic way. You know what is what. Why the P wave is there, the Q wave is there, why the T wave is there, and what is supposed to be happening in a normal ECG. Now we start going through the rhythm, the heart rate axis. Go through then the waveforms, P, Q, S, T, and if there is any E waves, look at the intervals or segments, PR interval, ST segment, or QT interval. There may be other abnormalities. And then try to interpret the ECG. And if possible, always compare with the previous ECG. That's very helpful. So whenever you are screening the ECG, verify patient's name, registration ID, and date and time. That's also important. The patient may be coming with an ECG. They're showing very much ST elevation. You are worried the patient is having an acute ST elevated MI. But then you see the date and you see there is 1 month ago ECG. So you were asking for why is the new ECG, latest ECG. And you see that what changes have been the patient ECG has gone through in the latest ECG. You identify how much damage is there or how much good we have done. If we're doing a primary PCI within the hours, the next 1 month later, the ECG may be totally normal. Make sure that the voltage is 10 millimeter per volt, millivolt and calibrated. There is the bar shaped before each ECG at the very beginning. There's the calibration sign. Screen for quality, whether the leads are correctly placed and if there is any noise. So my point is it really the patient ECG? I always look at the name and age. Is it really the current ECG? We can look at the date. Now, go through the usual way of what is the rate. Before that, we have to know the time period. One small box, we know that it is 40 milliseconds or 0.04 second. One large box, we know that. Now, look at this ECG. The first thing we know we have to do, NICVD is not been there. Calibration, that's not proper. The speed is there, 25 millimeter per millivolt. Everything is there, but the ID and the calibration is not present, not proper. Here, calibration is only 1/4. What about this one? What are we going to do about this one? There are ECGs which shows some normal P, Q, S, T, and this one doesn't have a P in front of it. Again, if you look at the rhythm strip, it shows P, Q, S, T. This one doesn't have a P wave, but a broad complex and T wave is there. Again, normal, normal, abnormal, normal, 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 normal. So occasional abnormal bits are there. What type of abnormality we'll be looking at that later on. And the calibration, you have to look at one, whether it is proper or not. 5 millivolt. What about this one? Look at the calibration, 20 millivolt. I will tell you a story. One day in a private hospital, I was asked to go to the ICU because they are having a serious problem with the patient. I went there, see a patient who has undergone 8 ECGs at quick succession. Why? They are saying, sir, look at the ECG. The waves are absolutely abnormal. Actually, they were recording the ECG at 40 millimeter deflection. So every minute abnormality is coming up very big and creating the problem. And they have done 8 ECG, one after another, not looking at the calibration, not understanding what is happening, what is wrong. And that we should be careful of, because this can happen to anyone. Proper lead placement or proper calibration, without that, you may miss something or you may misinterpret something. So, what about this one? No ID. And looking at this one, I think I have a very paper speed, 12.5 minutes again. Looking at this, I would have said, there is a sinus tachycardia, but it's not actually there. Because of the paper speed, the paper is going very quickly, the complexes are coming like this. What about this one? Here there may be ECG interpreting it as a normal heart rate, but you are seeing a bradycardia. Whenever you see something like that, the white complexes and bradycardia, always look at the paper speed. That's 50 millimeter per second. So if the paper is going very fast, the complexes will be wide apart, and all the waves will be looking very healthy, too wide. So that will create a false idea, giving that is boundary branch blocks or intraventricular conduction delays and bradycardia, which is not there. The same ECG with a normal speed and calibration. Is the lead placement accurate? That's the interesting thing. Limb lead placement may be inaccurate, chest lead placement may be inaccurate. This one, look at the calibration, all right, but P is inverted in here. Lead 1, current is going from left side towards the right side. Can it happen? That can happen if the patient have dextrocardia. What other things? If it is dextrocardia, then the chest lead will show that on the right sided leads, there will be bigger complexes. On the left sided leads, there will be small complexes, which is not here. Here, the QS complexes, the R wave is small in V1, V2, gradually getting bigger, and then it's much bigger in V6. So it's not dextrocardia, it's improper lead placement, left and right arm transposed. What about this one? P is negative, LVR, P is positive. Current is going from left side to right side. What about this one? The R wave is bigger in V1 and much smaller in V6. So here the current actually is going towards the right side truly. So that's a true dextrocardia. Look at this one. The patient is intubated. So that's an ICU setting. But is the lead placement in the chest, is it accurate? No. What will be the normal placement? Look at this one. The same patient, look at the previous placement of lead, the marking is there. So the ECG that is produced by this improper limb placement may not be accurately reflecting what is actually happening, what electrical activity is you are seeing in the ECG. Look at this one. V1, bigger R, V2, a smaller one, is it dextrocardia? V3, small. Actually, what happened? This one should have been here, this one should have been here. This transposition of V1 and V3. That's a very interesting one. Now, what about that's the proper, after proper lead placement, the same patient. Look at this one. Look at this one. After proper lead placement, the ECG is like this. For ECG, we have to count the heart rate. We know the heart rate is 60 to 100 beats per minute, but in children, the heart is supposed to be much higher. And there is a normal pediatric heart rate chart. At birth, it could be 130 to 190. At 5 to 8 years, 60 to 110. In a young man, 12 to 16 years, 50 to 100, it may be normal. Now, how can we consider and easily count the heart rate? Normal paper that we see in a ECG, the rhythm strip is for 10 seconds. So all the QRS complexes that you see in the 10 seconds and multiply by it with 6 will give you the heart rate. Or you can count the heart rate in 6 seconds and multiply it by 10. Then you will get the heart rate accurately. And if you get a ECG where it's a single lead, you cannot do that. Then you have to count it properly. In this one, 300 by number of large squares. 1 large square, 2 large square, 3 large square, 4 large square, 4.5. 300, 150, 100, 75, 60, in between 60 and 75. If let's say it's 65 or 68, something like that, that's very easy to count. There's an irregular one. And if it happens, look at this, heart is 89, but let us count. Here, if you consider the deeper spaces, heart rate 44, 78, 84, 73, that's not accurate. So we have to count the heart rate in 10 seconds, multiply by 6, or you can count the heart rate in 6 seconds and multiply by 10. Here to here, 1 second, 2 seconds, 3 seconds, 4 seconds, 5 seconds, 6 seconds, 5 big boxes, 1 second, 6 seconds, 1, 2, 3, 4, 5, 6, 7, 8, almost 1 there. So 6 seconds, 8 complexes, 8 and something very near, 80 plus. The heart rate, your ECG machine is saying it's 89. So you are very much near to the correct rate. So 1 big box rate is 300, 2 big box 150, 3 big box 100, 4 big box 75, 5 big box 60, 6 big box 50. That's enough. And 7 big box 45. You don't have to count more. And after that, you can actually say this is critical. The patient need to be taken to a cardiac hospital or emergency or something like that. So after the rate, already state the rhythm. Is it sinus? Is it atrial fibrillation? Also, you can have a sinus rhythm with additional abnormal beats. So that's the additional rhythm. Or maybe paroxysmal, in case of paroxysmal atrial fibrillation, you have a sinus rhythm sometimes punctuated by bouts of rapid rhythm, very irregular, chaotic. That's paroxysmal AF. So identify additional rhythm after start is stating the basic rhythm. And whenever you see the rhythm is sinus or atrial fibrillation, consider from where the complexes are coming from. Is it from the atria? Is it from the epijunction? Or is it from the ventricle? Is it from the sinus node? There will be lectures on that in later periods. So I will not be dwelling much more on that. Here, look at this one. I can see the complexes are more or less regular. And before each QRS complex, there is a P wave. So it's a sinus rhythm. Why sinus? If it's coming from the SA node, the current is going from right to left, from top to bottom. The P wave is supposed to be positive in lead 1, lead 2, I'm negative in AVR. Here it is. So it's very likely sinus rhythm. What about this one? I can see that 1, 300, 150, 100, 75, 60, 50. The heart rate is 50. And whenever you see that type of rhythm, we have to consider the basic rhythm, whether there is anything we are missing. P equals T. What is this one? P equals T. Again, the same thing. Would it be a P wave? Now, cutting away the lead 2 and just zooming it a little bit, P equals T, that's a P wave, almost similar looking wave in there. So each QRS complex is preceded by a P wave, but not all the P waves are followed by a QRS complex. Between two QRS P waves, one is passed through the AV node and stimulating the ventricle. One could not pass through the AV node and could not stimulate the ventricles. So we are having actually bradycardia because of 2:1 AV conduction block. What about this one? We are seeing the QRS complexes, and they seem to be regular, but there seems to be no relationship with the P wave. This is the P wave, P wave, P wave, something in merged here, P wave, P wave, P wave, again merged in here, P, 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 P. So there's complete atrioventricular dissociation with a marked bradycardia. And the escape rhythm that's coming from, we have to see the QRS complexes, is left bundle branch block type. So the escape rhythm is not coming from the junction, it's way below. And so that rhythm may not sustain. The patient may be jeopardized. The heart rate as a whole is very low. So this patient needs immediate intervention. What about this one? Very chaotic rhythm. But look at this one. White complex is smaller one, big complex, smaller one, narrow and bigger. And bouts of bigger complexes. Now look at the rhythm stream. This is the small one, this is the big one. So, and the big one, they are similar. The small one, they are similar. Go through like this. We can identify that P, Q, R, S, T. That's the sinus rhythm. So this is not sinus rhythm. That's a ventricular rhythm because the current do not follow through the normal circuit. The QRS complexes are wide. And this circuit is punctuated by these abnormal rhythms, which are sometimes couplets, sometimes triplets. And here it is 4 complexes. This seems to be a normal one, it's a normal one, and these 3 are not. So the basic rhythm was sinus, punctuated by the ventricular rhythms. Why ventricular? QRS complexes Y, T wave the other way around. So, and this is not preceded by a P wave. But we do not see any after delay. Why that happens? Is it related to any atrial fibrillation, fast ventricular rate, conduction delay, something like that? Those questions will be coming into mind. The first thing you have identified that there is a normal rhythm and there is an abnormal rhythm. And the abnormal rhythm is much faster. And that has to be taken care of. That's the thing you have to look at. What is the rate? What is the rhythm? Now the axis is actually the overall measured directional electrical activity of the heart. So normal axis, we know that between 0 to 90 degree. And how to determine axis? We don't need to see the accurate degree. You have to say that it is going 39 degree. It's 105 degree. All we need to see whether it is normal axis, right axis, or left axis. And that's a very simple one. If you find lead 1 and AVF both are upright, it's normal axis. Because the current is going towards lead 1, the current is going towards AVF. So it has to be in between them. When the current is going towards lead 1, but going away from AVF, the current is in that part. That's left axis shift. When the current is going away from the lead 1 and it's positive current is going towards the AVF, so that is a rightward shift. And when both lead 1 showing negative complex, AVF showing negative complex, the complex is here, superior axis. So careful analyze the total ECG for abnormalities in each of the waveforms. Look at the P waves. Are they too wide, too tall, look funny, or that means whether they are ectopic or not. Look at the QS complexes. Look for pathologic Q waves or abnormal voltage or white, whether it is bigger or not, vulnerable block, etc. Look at the ST segment, whether there is any elevation or depression. Look at the T waves and look for T waves if it is any of those there, or any other electrical activity. That could be spikes. Pacing spikes which doesn't produce any electrical activity. Missed beats, isn't it? So we have to carefully look at this one in a systematic way. P waves, always remember, they represent contraction of atria. So they are usually upright in 1, 2 AVF, and usually inverted in AVR. That's the normal P wave we should be looking at. Upright P wave and inverted P wave in AVR. What about R wave? They represent QS complexes, contraction ventricles. Height of R varies depending on the ventricular wall thickness. The higher the thickness, the higher the amount of current, the higher the degree of amplitude of the R wave or QS complex you'll be seeing there. V1 to V3 measures of our RV, they have thinner wall, so smaller R wave amplitude. V2, V4 to V6 measure of our LV, thicker wall, larger R wave amplitude. So R wave increases in amplitude from V1 to V6. Small R wave gradually getting bigger, and usually the biggest R wave are seen in V5 rather than V6 because of the position of the heart. What about T wave? It is usually upright in lead 1, 2, and usually negative in AVR. It could be negative in V1, but it's supposed to be upright in V4 to V2 to V6. What is this one? These are problems we may encounter. These are muscle tremor or maybe electrical interference. If that is so, we have to re-prepare the skin, ensure the patient is perfectly still, ensure that the leads are not problematic. The wandering baseline, this can happen if the patient starts taking a deep breath. Make sure that they're dry, and maybe we have to say the patient don't take long or deep breath. So the take-home message is that ECG is heart of cardiology. It's fun, educative, but sometimes mysterious. Systematic approach is really the key to success. Books, discussion like this, and lectures, all this can help, but only to a certain level. It's a habit of going through lots and lots of ECG, which is the most helpful practice in unveiling the mysteries of ECG. As Rafique sir is always saying to us, please, before trying to be an expert, just have a look at the ECG, go through the ECG, see the ECG, and afterwards, you will have a habit of immediately identifying what is the type of problem. And then you can look at it carefully and find out the actual problem, what is happening, why it is happening, why it is happening. So we should also remember, we should treat the patient. we should not treat the ECG. That is very true, because sometimes in case of Holter, in case of six-sinus syndrome, we see big pauses at night. We are saying this patient needs a pacemaker. The patient actually do not need a pacemaker because the patient did not have any symptom. So we should remember that even while we are becoming an expert or so, or we are trying to be an expert or so, we should remember that we should treat the patient, not the ECG. Thank you, everybody.
Thank you, sir, for excellent presentation. And the most important slide that you have shown at the last. Treat the patient, not the ECG. So it's an excellent presentation. So I'd like to request Professor Atahar Ali, sir, to say some words regarding the presentation. We have many dignitaries as a panelist in our session today. So I first request Professor Atahar Ali, sir.
Very excellent presentation. Tushar.
Yes. Okay.
You can ask for some questions from our participants, as it is really the basic about the ECGs. So there are some newer participants. You can ask some questions from the participants. There are some questions maybe in the chat box. You can.
Sir, we'll do that. If we have any question in the chat box, we'll discuss about that thing. But before that, I'd like to request you to say some words regarding the presentation of Wadud Chowdhury, sir.
This is a really excellent presentation regarding the basics of ECG, and really after a long time, I think this is the first introductory lecture from which we can start our the series of lecture again. That is what we say, that is always our Rafique sir always says that is the basics is the first thing. So we can continue our sessions by the basics things as well as the case-based discussion. So today's presentation was really excellent. Wadud's presentation is always something special. So today's presentation was really excellent. I appreciate things. Thank you very much, Wadud bhai, for your excellent presentation.
We have among us Dr. Rafique and Professor M. Zaman, sir. Saurabh, sir, can you hear me? I think
Sir, আমাদের মধ্যে কি আজকে বাঙালির বাইরে কেউ আছেন?
So I don't think so. আমার মনে হচ্ছে না।
আমি তাহলে বাংলায় বোধহয় কথা বললে ভালো হয়।
সজল স্যার আপনি কি শুনতে পাচ্ছেন? আমাদের প্যানেলিস্ট লিস্টে সজল কৃষ্ণ ব্যানার্জি স্যার আছেন।
Unmute, sir. Sir muted.
আচ্ছা।
আমি রিয়েলি ইমপ্রেসড ওয়াদুদের এই ইন্ট্রোডাক্টরি প্রেজেন্টেশনে, কারণ বেসিক ইসিজির এরকম ইন্ট্রোডাক্টরি প্রেজেন্টেশন পাওয়া মুশকিল। আর যারা আজকে এনজয় করেছে আজকের লেকচার, তারা নিঃসন্দেহে উপকৃত হয়েছে এই কারণে যে ওয়াদুদ একদম রিয়েল সেন্সে বেসিক কথাবার্তা বোঝানোর চেষ্টা করেছে, শেখানোর চেষ্টা করেছে, এবং আমরা সবাই এনজয় করেছি, রিক্যাপচুলেট করেছি। ওয়াদুদের প্রেজেন্টেশনের জন্য ওয়াদুদকে ন্যাচারালি মেনি থ্যাঙ্কস অ্যান্ড কনগ্রাচুলেশন। থ্যাংক ইউ।
থ্যাংক ইউ স্যার। আসলে আমার কিছু কোশ্চেন ছিল। রফিক স্যার, যখন আমরা বেসিক ইসিজি নিয়ে কথা বলি বা অ্যাপ্রোচ টু ইসিজি নিয়ে কথা বলি, তখন আমার কাছে মনে হয় কি যে আপনি যে কথাটা বলেন যে একদম প্রথম থেকে সবকিছু ভালো করে না বুঝে বরং একটু ইসিজির প্যাটার্নটা বোঝার চেষ্টা করা বা করা, আপনার এই মেসেজটা বোধহয় সবার কাছে যাওয়াটা অনেক ভালো হয়। আপনি যদি আবারও সেই কথাগুলো স্যার আবার বলেন সবার জন্য।
আসলে তো ইসিজি তো ট্রেসিং, এটা একটা। সেকেন্ড, 90% ইসিজি ক্লিনিক্যাল প্র্যাকটিসে কিন্তু নর্মাল। সো আমি সবাইকে বলি যে ইফ ইউ ক্যান আইডেন্টিফাই নর্মাল ইসিজি, then you have actually diagnosed 90% of your patient, and then you deal with the 10%. For those 10%, even if you don't know, and if you know it is abnormal, ask somebody else. hey, by the way, I look at this ECG, it doesn't look normal, what is it? কিন্তু একটা জিনিস যেটা হলো যে এই ট্রেসিং ইসিজি হোক, একো পিকচার হোক, চেস্ট এক্সরে হোক, একটু একটা মিনিট সময় দিয়ে carefully look at it. And look at it the way Wadud described, systematic way, rhythmটা কি, rateটা কি, এটা কি, তারপরে একটা final conclusion, is it a normal ECG or abnormal ECG? আমাদের একটা general tendency আছে to look at something, এটা সবারই, এইটা এইখানে abnormal. No, look at the normalcy first and then look at the abnormal. I mean, এইটা যদি practice করেন সবাই, then you will see that at the end of the year you will be able to read ECG. So please take a systematic approach in reading these ECGs, starting with normal ECG. Because when you are starting out, if you go for the complex ECG, then you will get confused, you will get discouraged. So what I do when I try to learn something, like if I want to learn driving, I will learn on an empty road which has no pothole and which is straight. And once I have driven there for maybe 10-20 hours, then I will take a curvy road. Then I will take a road with multiple bends. Then I will drive in traffic. And same thing should apply for ECG reading or any kind of picture that we see in medical practice. Thank you.
Thank you, sir.
আচ্ছা, এই তুষার, আমি স্যারকে একটা কোশ্চেন করি, রফিক স্যার।
Yes.
হ্যালো স্যার। স্যার আমাদের হল্টারে যে মাঝে মধ্যে, স্যার আমাদের তো হল্টারে দুই ধরনের থাকে, কতগুলোতে চ্যানেল থাকে, কতগুলোতে 12 লিড ইসিজি থাকে। স্যার হল্টারের 12 লিড ইসিজিটা কি আমরা এই 12 লিড ইসিজির সাথে রিপ্রেজেন্টেটিভ ধরতে পারি?
Holter 12 lead ECG, I don't pay attention at all. একসময় স্টাডি করা হয়েছিল, যেমন ইস্কেমিয়া বার্ডেন দেখার জন্য যে এসটি সেগমেন্ট দেখতে পাই, আর্লি 80s অনেক স্টাডি হয়েছে, বাট ইন জেনারেল আমরা এখন আর ওইটাকে 12 লিড হিসাবে ইউজ করি না। আর 12 লিড ইউজ করলে ওইটা একটা এক্সট্রাপোলেটেড, বিকজ লিড তো 12 লিড না আসলে। সো আই ডোন্ট থিঙ্ক দ্যাট শুড বি ইউজড ফর 12 লিড। বাট রেয়ার কেসে এমন হতে পারে, যেমন প্রিঞ্জ বাটাল এনজাইনা আছে, we see some ST elevation, suddenly patient having chest pain. You may think, yeah, that is okay, but we don't use 12 lead, no.
স্যার আসসালামু আলাইকুম স্যার। আমি স্যার একটু জানতে চাই স্যার, if we see some sorts of ST depression in the date, মানে any time patient walking or doing some exercise or going here and there, মানে সেই পিরিয়ডে অনেক সময় ST ডিপ্রেশন পেশেন্টের 12 লিড ডিসিজে পাওয়া যেতে পারে, আমরা কি এটাকে ইস্কেমিয়া হিসেবে নেব না স্যার?
I'm talking about Holter monitor.
In Holter monitor, sir.
But the leads are not placed in 12 lead position.
But still, মানে স্যার যদি আমরা প্রিভিয়াস পেজগুলোতে দেখি যেখানে এসটি ডিপ্রেশন ছিল না, বাট এখানে এসটি ডিপ্রেশন পেলাম, সো এটাকে আমরা নিয়ে বলবো কিনা?
Yeah, I mean that comes to the question, যেমন আমরা 80s এ এবং early 90s এ lot of দেখতে চেষ্টা করছে, but I mean yes, as I told you, that if I put a ECG and somebody having chest pain, somebody has fringe metal angina, you can see this ST elevation. But can I use it in routine practice? We don't use it. I mean, is it possible if somebody wants to do a study on this? That will be a great thing. But in clinical practice, I don't know, Hafiz আছে এখানে, we don't use 24-hour monitoring to look at ischemia at this point. Thank you.
Thank you very much, sir.
সেটা হলো যে পি ওয়েভটা কোন সিঙ্গেল স্ট্যান্ডার্ড লিডে দেখবো। আসলে কোন একটা সিঙ্গেল স্ট্যান্ডার্ড লিডে দেখা উচিত না, পি ওয়েভটা সবসময় দেখা উচিত দুটো লিডে, লিড টুতে। কারণ ইউজুয়ালি যে হার্টের যে এক্সিসটা, যে আমার এখানে যে পরিমাণ আছে এবং এসএনওড থেকে এফিনোডে যাওয়ার যে কারেন্ট যাওয়ার যে এক্সিসটা, সেটা কিন্তু একই রকম। সেই জন্য লিড টুতে পি ওয়েভটা ভালো দেখাতে আমরা ওই জন্য রিদম ওখানে নেই। আরেকটা হলো V1টা খেয়াল করে দেখেন, হার্টের হলো 1/3 টু দ্য রাইট, 2/3 টু দ্য লেফট অফ দ্য মিড লাইন। এখন V1টা বসে আছে যেটা, সেটা কিন্তু এফটিএম এর উপরে বসে আছে, কারণ সেই সবচেয়ে কাছে থেকে এফটিএল অ্যাক্টিভিটি গুলো দেখছে। এই জন্য V1-এ কিন্তু আমরা রিদমিস্টিকটা ভালো পাই। এখন ধরা যায় একটা মানুষ খুব ওবেস, সে ওবেস হলে কিন্তু তার ডায়াফ্রামটা অনেক উপরে উঠে আছে, তার হার্টটা কিন্তু একদম হরিজন্টাল হয়ে আছে, তখন কিন্তু কারেন্ট এসএ নোড থেকে এভি নোড যে যাচ্ছে সেটা কিন্তু অলমোস্ট টুয়ার্ডস দা লিড 1। আমরা হয়তো দেখবো পিওএফ ওখানে সবচেয়ে ভালো দেখা যাচ্ছে, ইভেন বেটার দেন লিড 2। কাজে এটা নির্ভর করবে যে আমার হার্টের পজিশনটার সাথে অ্যাকচুয়াল যে আমি পিওএফটা সেটা কোনখানে ভালো দেখা যাচ্ছে, আমি সেটার উপর নির্ভর করে আমি কি ডিসিশন দিব।
একটা কোয়েশ্চেন আসছিল অগমেন্টেড লিড। So if you look at early EKGs, all the leads were bipolar. And then there was an attempt to create unipolar lead. And those are the AVR, AVL, AVF, among chest lead. If you are a true physicist, you will never call them true unipolar lead, because there is some potential on the other end. But in reality, we call those as unipolar lead. So please remember that lead AVR, AVL, AVF is so-called unipolar lead. V1 to V6 are so-called unipolar lead. And 1 to 3, these are true bipolar leads.
Thank you very much, sir. It's almost 11 p.m. now, so in Bangladesh time. So we're near the fag end of our program. I'd like to request Professor Abdul Jamil sir to say some word and have the closing remark. Abdul Jamil sir.
Thank you,
Jamil sir.
Tushar. Thank you, Tushar. Wadud is a great teacher. So while I was doing fellowship, he used to teach us the long case and short cases. And I learned a lot of things from him regarding medicine. Later, during my fellowship in cardiology, we also had some interactions and learned many things from him. And he is always a good teacher. He delivers everything so easily and nicely, as difficult things also he presents very nicely. Thank you, Wadud, for elaborate lecture and nice lecture on basic ECG. Thank you very much.
নেক্সট ডে কবে হবে, কিসের উপর হবে একটু বলে দিবে?
Sure.
Sir, bolchi sir. So as you know, after a long gap, we have started the program again. So today is 6th July, and our next presentation will be on the third Sunday of this week, of this month. So 14 days later, and the topic will be case-based presentation, and our next presenter is none other than Professor Chowdhury H sir. He will have something new to talk about, and the topic will be delivered by Ahsan sir later after the program. He will tell us on which aspect he wants to tell. Still then, this is the end of our session today. Thank you all the panelists, participants, and also our scientific partner, Bexico Pharmaceuticals, for continuing the program. And till next episode, this is good night for all the participants and our respective panelists. Thank you all.
আমরা একটু প্ল্যান করেছি যে একটা থাকবে যে বেসিকের উপরে এবং পরের সেশনটা হবে ক্লিনিক্যাল বেসড, এরকম যদি করা যায় আর কি।
I think that's a good idea.
This
So
এরপরে স্যার মিস্ট্রিজ নিয়ে বা পিএফ এর নানা রকম নিয়ে কেউ একজন কথা বললে ভালো হয়। তারপর
আসলে আপনার যেমন আজকে বেসিক ইসিজির এবিসি হলো, আমাদের পরের সেগমেন্টে পরের লেকচারটা হবে ক্লিনিক্যাল সিনারিওর উপরে, যেটা হাফিজ আহসান স্যার বলবেন। তারপর লেকচারটা হবে পি ওয়েভ এবং পিআর সেগমেন্টের উপরে, সো দ্যাট উই ক্যান scientifically progress, how to assess ECG, how to read ECG.
All right, thank you.
Thank you, sir.
Thank you.
Sir, good night, sir.
Good night.
Atahar Bhai, Tushar, Khuda Hafiz.
Thank you, Wadud bhai. Excellent presentation. Thank you.
Thank you, everybody. Assalamu alaikum. Good
Assalamu
night.
alaikum.